Okay, I've got chapter 18, I believe, up on my screen. Can somebody tell me if they can see chapter 18?
It's there.
You can hear me okay?
Yes, ma'am.
Okay. Who is this, Mariah?
Mariah, yes.
Okay. All right, we're going to finish up. Now, if I've done my job correctly, this is being recorded, and I know a lot of you have little ones at home and other things going on, so we'll get together and figure out what system works best during the time that we're out. I don't mind just recording them and having them available for you guys too, versus trying to make you sit and listen to them here. But we're going to talk about advances in detecting and monitoring periodontal diseases, and this is really, to me, one of the interesting chapters here, because it's got some of the newer information, and it changes all the time. So even the information in this textbook is old by the time it gets published. But what are some of the objectives for Perio and monitoring? We want to evaluate the role of using adjunctive diagnosis aids as a predictor for periodontal breakdown. We see a patient every day, and we need to do some sort of a risk assessment to see what type of risk they're at for having future breakdown. And we want to explain the advantages and disadvantages of the various methods, as well as distinguish the type of patient who may benefit from these certain types of diagnostic testing. So you all know what the mouth looks like and what the bacteria in the mouth looks like. It's a very busy place. You've got all sorts of stuff going on. You've got some studies are showing, or literature saying, up to 700 different potential bacteria in a particular mouth. So you've got, everybody's got a certain set of bacteria, and it's supposed to be there. So we've got our resident bacteria, the good guys, and we've got our bad guys. And remember, it's that red complex bad guy that we are really more fearful of. So we're going to be getting into that as well. You've got your early colonizers, which are your gram-positive aerobic bacteria, and your late colonizers, which are more of your pathogenic bacteria. So conventional assessment methods for recognizing periodontal diseases are what we do in clinic. We're using our probing, we're using our clinical attachment level and clinical attachment loss, and we're using our radiographs and bleeding sites to determine what's going on. Now, all that tells us is what has already happened for the patient. But we would ideally want to detect periodontal sites that are actively losing right now, that are in active disease, or in the future are likely to have breakdown. And that's difficult to do because our methods are only assessing past disease activity. So right now, as we've said, the standard is the periodontal disease activity is if you see a 2 to 3 millimeter change in the attachment level measurements. That's 2 to 3 millimeter change, all right? We give ourselves that plus or minus 1 millimeter. The adjunctive tests for the evaluation of periodontal disease has been developed, and we're going to talk about each of these groups. You've got a gingival crevicular fluid assay, a microbial assay, as well as genetic assays, and we're going to talk about each one of those. But this is in chapter 18, the supplemental diagnostic tests, and it's again has everything in a nice chart form for you, and we're going to go into each of these just a little bit. Okay, the advantages and limitations of each of what we're going to go into tells you everything you need to know. You know how I like these things, right? Cultures, advantages and limitations, the DNA probe assays, advantages and limitations, the microscopic tests, as well as the gingival crevicular fluid assays. So let's start talking about the gingival crevicular fluid assays. And those, as you know, originate from the gingival crevicular fluid, and that fluid comes from the lamina propria, or the connective tissue. And as inflammation increases, the gingival crevicular fluid flow also increases, bringing with it tissue breakdown products, you've got your enzymes and other inflammatory and immune substances. So these gingival crevicular fluid, it's collected on paper strips. And the substances found in the gingival crevicular fluid indicate an increased risk of clinical attachment loss and bone loss. So you've got your host-derived enzymes, your AST, your aspartate aminotransferase. Now remember that ASE is an enzyme. Aspartate aminotransferase, your collagenase, and your B-glucuronidase. You've also got your prostaglandin E2, inflammatory markers. So you're placing these paper strips into the sulcus or the pocket, and it's absorbing the fluid, the gingival crevicular fluid, okay, and then you're doing tests. So it's looking at the components of the gingival crevicular fluid, and it's reported to be associated with an increased risk of clinical attachment loss as well as bone loss. You've got your aspartate aminotransferase and your collagenase that's being tested. Now again, collagenase is one of those big enzymes that, if present, can decrease the amount of collagen. You've got your prostaglandin E2, which is a metabolite of the arachidonic acid, and that again is associated with inflammation. There's something called BANA testing, and I've done this in private practice. The book says it's just for research purposes, but private practices have this. It's a bacterial plaque sample that's taken, and then it's exposed to substances that's degraded by specific enzymes. The bacteria produce substances called BANA, okay, and I'm not going to make you spell that out. Benzoyl arginine 2-naphthabamide. Okay, so if you've got a positive test, if you've got a positive BANA test, that may indicate the presence of one or more of the red complex bacteria. That's all it tells you, is that you've got red complex bacteria. It doesn't tell you which one or all of them or how much. The Treponema denticola, the P. gingivalis, and the T for synthesis. Okay, they all produce a trypsin-like enzyme that shows up in the BANA test. And it's really simple to use. It's chair-side, and that's how big the box is. The office that I usually go pick up the BANA test so I can show you all is closed right now because they're not seeing patients, so I couldn't pick it up, nor are we on campus, so I can't show you. But we would use this chair side just as a screening if somebody had a pocket area that wasn't responding. Okay, so you're putting a swab on, you're folding it over, you're placing it in the machine, and in about 10-15 minutes, you get this reading. And it's a color chart, okay? Is it colorless? Is it pale blue or dark blue? So again, this is telling you just, do they have certain bugs? A weak positive, you know that they might have some. They're at, certain risk, but if they've got a positive, you know they've got the red complex and you need to be a little more aggressive. So we've got these microbial tests that are more specific as well. And they're used for research as well as in clinical practice. These culture techniques look at the growth of certain bacteria found in the periodontal pocket. So you have to take a sample and it shows the specific bacteria, and it can also show the sensitivity to certain antibiotics. There are microscopic techniques that are used which identify the bacteria in periodontal pockets, and there's different tests that are available. The nucleic acid, the DNA probe analysis identifies bacteria through DNA sequence. The nice thing is with that is it's really good on refractory cases as well as implant sites prior to placing the implant, because you need to know that that area is healthy before you place the implant. So it's really used for specific sites. It identifies the DNA sequences to with what's present subgingivally. You don't need to do this routinely on patients, but it's available. phase contrast microscopes, they were very popular in the 70s and early 80s, and they came out of fashion. They are popular again. It's a great patient education tool. It's fabulous. And it's now, instead of having to have a separate TV monitor, it shows up on a computerized screen. But you take a plaque sample, you put it under the microscope, and voila, you bring this slide up and you can show the patient what types of bacteria, the amount of bacteria, and the activity of the bacteria. Is it just a few guys, and are they very lethargic, just kind of laying there? Or is there a bunch of stuff and they're jumping all around and just having a party? You've got your immunologic assays, your enzyme-linked immunosorbent, I can't say that word, assay, your ELISA. It's not used clinically, but it's used in research. It identifies specific bacteria through labeling of a fluorescent secondary antibiotic. You've got your genetic assays, your interleukin 1. Remember, that's one of the bad guys.
Your sister sweet kisses.
Secreted by the macrophage, and that is inflammation and bone loss. So, is your patient a interleukin 1 genotype? You have your periodontal susceptibility testing, your PST, and that's using saliva. It does help determine the interleukin 1 genotypes because, again, those patients are more susceptible. And if you're an interleukin 1 genotype positive and a smoker, it's a synergistic effect, so breakdown is very likely. What are some of the clinical applications of this? A lot of this can be done chairside, but these are supplemental tests that you can do for the patients, and they may be useful in patients to help determine periodontal disease activity, if they're not responding, or if you think other treatment might be necessary. In the 80s, when we were doing SRP for our patients, we automatically put them on amoxicillin or tetracycline and metronidazole. Automatically, 2 broad spectrum antibiotics to kill most of the pathogens that are probably involved in periodontal disease. We just arbitrarily did it. Now we know that that is not best practice. We want to see what the body can do first and then go in and target the specific areas with specific medications to fight the infection. So no one clinical test is available currently that's going to determine all the site activity and breakdown. So we need to use a combination of what we do clinically and some of the newer diagnostic tests that can be used to provide a more complete information in treatment planning. And some offices are really getting on board with this. Additional bacterial tests are used for site-specific treatment and to help us assist treatment and to rule out other causes of disease. All right, so let's get a couple of review questions here, just for thought-provoking purposes, because I don't have a microphone or anything here. Which of the following tests is highly sensitive for specific periodontal pathogens present in a subgingival sample of plaque? Okay, and that's the DNA probe because it's asking for highly sensitive, all right? And that's usually the DNA. Which of the following is the role of genetics as a risk factor for periodontal disease? Okay, and it's that interleukin 1. 30%. Okay, folks, we survived our first day of distancing. What I'm going to be doing is transferring this and putting it online as well. Do I have questions on anything from anybody?
No, Misty, but we missed you.
Okay. All right. Thanks for hanging in there with me, folks. It's going to get better, I promise.
Hey, Miss D.
Bye, Misty.
Bye. Thank you.
Hey, Miss D. Yeah, never mind.